What was your first experience of suturing like? If you're like my guest Nabeel Cajee, then it was probably like, you know what, I got this. He had a background in embroidery, but for me, I was absolutely hopeless. And to be fair, I've improved a lot since the first days in dental school, but there's so much I still need to improve on, which is why I found you one of the best people to teach on sutures. This guy is brilliant. He's got a whole online portfolio of videos to watch, and it is something that's really helped me, and I'm continuing through his course, and I want to bring him on to share with you some nuggets of inspiration to improve your suturing come Monday morning. We covered this in the episode, but there's two types of courses. There are courses that you do which will ultimately, it may not be the main goal, but ultimately it will improve your return on investment, or it will give you a return on investment. So I know that if I start placing implants and I go an implant year-long course, it might cost me a lot of money on this 1 year-long course, but I know that there'll be a return on investment. I can offer my patients implants, and that should reflect in my bottom line. That shouldn't be the reason I do the course, ideally, but it will have an ROI. There are other courses that you do and other things that we purchase, like microscopes, for example, or suturing, for example, that you do because you know that you can give the highest quality of your care to that patient. One of the things that Nabeel says that when you place a suture, that is your signature of the surgery. And I love that saying, right? And to be fair, from my experiences with suturing, I can definitely do with a helping hand. Hence why I've come to this sort of episode, and I think I can share this with everyone to help you all. In this episode, we're going to cover what are the types of sutures available. If there was one suture you had to stock in the practice, which one would it be? And why you might need to venture into different types of knots and different types of sutures. The protrusive dental pearl I have for you is something that we practice where I work in Reading, and every time we do an extraction, as well as giving the verbal post-operative instructions, we'll also give written post-operative instructions. But one thing we did around about 18 months ago is we recorded a video. It was one of my colleagues, Susie, at the practice. She is just explaining to the camera what you need to do, exactly the same kind of stuff that we were giving verbally, but now through a video format. And after analyzing the stats after about a year, a lot of our patients are clicking on this. So even though they've been told verbally, even though they have the sheet, a lot of our patients end up clicking on this YouTube link. So essentially after the extraction, the nurse knows to just go in the templates, automatically send this email because they've had an extraction, and that's got like all the reminders for them. And a lot of our patients benefit from this. So the pearl here is consider any procedure for which you give a post-operative instruction, and you want to go really a level beyond, then I think if you can record a video, whether it's on YouTube or one of my favorite programs now, Loom, you can visit loom.dental to learn how that works. So you make a Loom video of you just speaking to the camera. It'll be you in the corner and some, or you can make yourself big as well, and you just explaining the instructions. You can communicate whatever you want through a video message to a patient. I think it really adds to the level of care that you're giving, and I think it's something that's quite innovative, and it's 2022, so this is the future. I think this future is video communication and being able to reinforce what you say in the surgery through video. And I think that there's an opportunity here for marketing. When the patients watch your video, and if you make it public, then anyone on the internet can gain some advice after extractions, and that can help you with search engine optimization, or your patients, once they watch the video, they're like, you know what, my dentist is awesome, I'm going to share this link with anyone who needs it, or the next time they need to give a dentist recommendation, they'll be like, oh, you know what, I'm going to recommend Jazz or Susie or whatever, because after I had my extraction, they even sent me a video of them explaining everything, and I felt really well looked after. So pearl is to think about, could you implement a video letter to your patient as part of post-operative advice, or any message that you want to send to them after the appointment? Let's improve your sutures with Nabeel Cajee. I'll catch you in the outro. What's the pathway into implant dentistry in the US? I'm sure there's many pathways, but what was your pathway?
Yeah, my pathway was really the year after I graduated dental school. In dental school, I didn't place a single implant or restore a single implant. It was really right after I finished dental school. I found myself as a resident in a trauma center, and I was an advanced general resident. And part of our charge was to restore all of the implants that the oral surgery residents placed, and those were just tons of trauma cases. So my very first case, the day after dental school, starting in my residency, was an all-on-4 quadzygomatic.
Wow.
Honestly, that was my very first case.
That's the craziest first case I've ever heard of.
Yeah, it was like welcome to dentistry, quadzygomatic, and I just loved it. I just loved, everything about like the implant pro side. And then part of that year, I got to spend about 4 months just on oral surgery service. And I picked up a lot of like the base surgery skills that way. And at the end of that year, I said, it wouldn't take too much more for me to be at the point where I could take my patients just start to finish. I want to place the implants right where I want them. I want to restore the cases as I want to. And that really got my journey started.
It's fascinating, I mean, as Steve Jobs said, something I've mentioned on the podcast, whenever I'm speaking to a guest, I like to understand their journey. And since I've already hit the record button, you mentioned something really cool about your journey. Dr. Nabeel Cajee, welcome to the Protrusive Dental Podcast. It's great to have you. It's late night in California. It's early morning in Reading, and I really appreciate you making time. You're a father of an 8-month-old girl. I love your Instagram. I love you sharing everything. And it just makes sense. So on that point of, connecting the dots, it makes sense, your journey, your evolution, where it started in your residency. And there's always, in everyone's journey, an element of luck and timing involved. Like, had you been in a residency where the direction and the mentorship and the cases, and your first case wasn't a quad zygomatic, right? You may have been into a different niche within dentistry. But it's amazing how that blossomed, and then now it makes sense with the Suturing Masterclass, and we'll talk about that later. But it kind of, when you look back, does it make sense now how you evolved in this direction in your career?
Well, honestly, and if I were to even dig further back, as a child, my mom would embroider, and she didn't have any daughters, so she'd actually ask me to help her. So I think those base skills as a child, embroidering with my mom, later on, when given the opportunity in residency, it was just fun. It was just fun to jump into those surgery cases and then build from there.
And were you good at suturing straight away because of the hand skills that you had from embroidery?
I think that may have played a role, just feeling very comfortable with needle and thread. But honestly, starting right out of dental school, I didn't know a lot of suturing techniques. I think very few people leave dental school with this whole arsenal of suturing techniques ready to apply in various clinical scenarios. So I think I was inclined toward it. And then given the mentorship specifically of a Dr. Gaffapour for me, he really built my suturing skills as a resident and gave me a foundation to springboard from. And, that's where then I was able to build from there and just grow. And I just love sharing it at this point.
It's interesting to know that, because when I think back to my learning of sutures, I remember being, I think it was second or third year dental school, and it's a 5-year course in the UK, and we get to it's foam. We're practicing on foam, and me and this one guy, so there's a group of 8, and me and this one guy were just completely hopeless, right? And the reason what prompted me to reach out with the Suturing Masterclass and speak to Rex and doing the course, and I've got the sort of models here, and I'm going to show them in a moment and stuff. I love it. But the reason I got into it is because I had this incident where I was suturing and things weren't going so great. And at the end, my nurse, the way nurses communicate to us, or DAs for you guys, the way they communicate to us in a very subtle and beautiful way that maybe you should do some C in this is, the implantologist, he does it differently. When they say he does it differently, that's when you know that, okay, I think I need to revisit my suturing skills.
And I think that's it. You seem like many GPs, at some point you don't stay a basic restorative GP. At some point, interests grow. Some people, it might be orthodontics, but some people are surgically inclined and they want to build in that direction. So I think if you want to build in that direction, all of a sudden you're going to start doing more surgical extractions, get into implants, get into these surgical scenarios where you're looking at tissue that you want to bring together. And you say, wait, if I want to bring that tissue more coronal, how would I do it? If I want to bring it down, how would I do it? If I want to close with tension, reading those scenarios, how would I do it? And that's all of a sudden where you're like, okay, I know that's single interrupted, but dropping these single interrupteds it's just not getting me where I want to go. So what could I do to actually get there? And what techniques are out there to do that?
You're so right. The question that how would I do that, and that's the question I ask all the time. So in my 3 years, obviously you're in the implant field, and your niching and your surgical background has influenced you further to go deeper into that field. For me, I'm very much a general dentist. I like treating all sorts of cases. I'm ortho restorative. But in the last 3 years, I did my first full canine to canine palatal functional crown lengthening case. That was my first thing that I did in a way. That was a big feat for me. So then I remember revising the night before, and then one of the questions was, my sequencing, writing everything down, my protocol. When I'm doing something for the first time, a bigger case like that, which is a step beyond for me, a step above for me. And one of the questions was, how am I going to suture this? Is my single interrupted going to be enough, kind of thing, right? So I'll pitch you that at the end. Okay, how would you close such a case? And we'll talk about what type of sutures you use. It'd be interesting to know from you. But that was one. And then doing more wisdom teeth from my experiences in Singapore and being influenced by someone called Neki Jamal in Canada and his course and stuff. So yeah, definitely I've seen the evolution in surgery, and that's why I think I've recognized that, I need to up my skills here with suturing, and you're the man to help me, Nabeel. I can see that already. So let's dive in with the first question, man. I was taught Vicryl. Now, Vicryl is a brand, right? Vicryl is a brand. It's a PGA. It's polyglycolic acid, right? So that was the first suture that was taught to us as students, and the sizes, which I think will really go down back to basics. Just explain a moment about sizes and what it actually means for the newbie dentist listening. And that's the first sort of suture that we learned. Is that the universal suture? Is that if you only had one, would it be that one?
Great question. I'll go back to what are the sizes of sutures. So there's something called the U.S. Pharmacopoeia system, and that's what designates the sizes. So it starts off as 0, and that's actually the biggest suture you can get. We will not be using that in dentistry. That'll be to pull muscles and big structures in the body together. And then it goes, it just goes further and further up. So, then it goes 1O, 2O. It's all these O's, but, generally in dentistry, we use between 3O and about 5O, 6O. If you get into more microsurgery techniques, and that's, say, periodontists that are now using ophthalmic grade sutures for really tying that papilla gently together, they'll go even further to 7O, 8O using microscopes and all of that. But let's keep it basic, right? For the surgically minded GP, I would say stick to a range between 4O and 6O, right? 3O is a good one, a 3O Vicryl, but what you'll see is the larger the suture is, the thread, you'll tear the tissue more. You actually want a smaller suture. So 3O Vicryl is a good one. One of my personal favorites is the 4O PGA. I won't use the brand name because you can get any of them. That is a favorite of mine. However, when we look at sutures, we look at different categories. So that you'll see, absorbability would be one, knot retention would be another. How long does it hold? Under tension. Let's see here, a price, the economy of sutures. And unfortunately, when you take all of those different categories and you stack it against sutures, there isn't one suture that has it all. There's some that come close.
I wouldn't think so. Just like in restorative dentistry, there's no one matrix system that's best for all class 2 restorations. And I was definitely expecting you to say that. Can you give us a 1 minute guideline as to Nabeel's recipe book in terms of the single erupted in a normal case? Would you use 4O Vicryl? And then for surgical cases, or is every case so unique depending on the tissues that you actually might change even between certain type of surgeries?
Yeah. So I would say, and this is with a caveat, that in the right clinician's hand, the suture choice doesn't actually matter, right?
Okay.
However, there are sutures that are better for certain clinical scenarios than others. So to close some grafts, there are some periodontists that will use chromic gut.
Yeah, what is up with that name? Like chromic gut, it just sounds like what does that name derive from? It just sounds horrible.
Yeah, it's just, in the gut being like the cat gut intestines, and chromic formulation to make it last longer.
So it's actually made from the intestines of a cat.
Maybe originally, but I think now there might be a little bit more synthetic material used in them. But those materials are more natural materials. And for me, I wouldn't think about using a chromic gut in a grafted site because you do have more of an inflammatory response from the breakdown of the suture. But that's me. I want something that's like inert to the tissue. I would probably use a monofilament synthetic, which won't trap bacteria, which won't trap the plaque on the threads, as well as wick bacteria onto the threads, things like that. But in the right clinician's hand, it works. Right. Mm-hmm. However, when we're looking at cases, say as a surgical GP, as a GP, you can do all the surgery cases you want to as long as you're doing them to a high level of care. And I think that's where the suturing choice then does make a difference. Where if you were to be in a scenario and you have to explain your work and someone's like, why are you using, this suture? Is that the best suture for the job? I don't want to be in a scenario where I'm saying, it's a great suture. It works in some people's hands, but
I just use the same one for everything. It works.
I just use the same one for everything. I want to be in a position saying I use the best material for the job. And in that case, you have the different categories, which would be braided sutures, non-braided sutures, which is kind of like a twined rope or fishing line. The difference in how the threads are laid out, the synthetic and natural sutures. And then the variances between them. So Vicryl is a braided synthetic. It has the advantage of not having as strong of like an immune response or inflammatory response as it breaks down, but it does wick stuff into it. It does wick debris into the suture.
Oh, it's covered in plaque usually in my hands.
Yeah, sometimes when I've used it, patients look back and they say, "I have something growing, an infection." You're like, "No, you don't. Just run the course."
Nabeel, the difference between your sutures and my sutures is that when they come back to see you, you've actually got a suture to cut. By the time they come and see me after about a week, there's the patient may think, thankfully, that this suture absorbed, but from doing your course already, I know that actually absorbability can take up to 60 days. I was like, what? Okay, so obviously my sutures are falling out. And not absorbing. so that's the difference between your sutures and my sutures. You've probably seen a lot of yours come back, whereas mine have just gone ingested.
We can change that. I think some of that might come into the knot tying.
Yes, 100%. It is exactly that. If I was to break down exactly the stage, I think my choices and stuff is okay. But it comes down to the knot. And I'm sure we can explore a few tips there. Anything else so obviously it's a podcast episode at the end of the day. It's to entertain, it's to educate as people are driving and stuff. Any key points you want to cover before we go to the next question in terms of the wide sort of range of different sutures, even in terms of stocking them as a practice, like how crazy do you want to go? Like having different types. Is there a more economical way to do it?
Yeah, I think I think you don't need to have tons of types. I think Vicryl 4.0 or PG 4.0 is a great one for like your everyday extraction, things like that. And then having one other or two other synthetic monofilament, say for more delicate positioning of soft tissue, a nylon 5.0 or polypropylene 5.0. Those two sutures can, a nylon or polypropylene 5.0 and a 4.0 Vicryl, that can carry you.
Mm-hmm. Mm. I mean, if you're speaking to a dentist who, let's say, works in an emergency clinic and all they do is extractions and that's it, they don't do any fine soft tissue work and they just get people out of pain, then the only one they probably need to stock to keep, in terms of law economics would probably be a 4.0 Vicryl. Is that fair to say?
Yeah, I'd say a 4.0 Vicryl. It's a great suture for extractions. I'm not a big fan of the gut sutures for extractions, especially sometimes in wisdom teeth, especially if there's muscle pull, it just breaks them apart. So the Vicryl can actually have some strength and fall out if the patient doesn't come back for a follow-up.
Yes, I can vouch for that one. Nabeel, what are the most essential types of sutures to know? What I mean is, I can do a single interrupted, I can do a horizontal mattress, and before coming to your course, that's all I know, okay? So what are, as a young dentist, newly qualified, which ones do you absolutely need to know? And then as you evolve your interest, what are the kind of sutures that you think that we should know as a clinician?
Good question. I think everything starts with the single interrupted. But and I think it's good to practice. Anytime you get a chance to suture, just drop that single interrupted. But at some point, you'll realize that doesn't carry you far enough. So a suture that I think every dentist should know, and one that I want you to place tomorrow, is the Laurel suture. Okay. Once you it's a twist off the horizontal mattress that you know, and it's one step above that, right? Once you place the Laurel suture, you're gonna get hooked on suturing, because you're gonna look at your flaps come together beautifully, and you're gonna say, this one simple variation of something I was doing all of a sudden led to a big difference. And so that's gonna be the next step. And then from there, there's all the continuous ones, and I think it's just going to instill a fire in you to learn more and more.
I think the continuous ones is something that I'm looking forward to learn from the course, because at the moment I'm on like decision making, the kit and stuff. The kit just arrived 2 days ago, which I'm, I'll just show this now.
It just cleared customs.
Yes, so it cleared custom. So this is cool, because I was speaking to Rex and I was like, look, I really want to do this course, but I don't want to do it just the lectures only. I want to experience the hands-on. They're like, well, we haven't really shipped out before. And I was like, listen, make it happen. Let's see if we can make this international now. And I can, these blades made it through, man. These blades made it through.
Amazing.
You got everything in here. Yeah, I know, right? So you got all the different types in here, but these models are something else. And they're the same ones. What I love is that it's the same ones that you use in the videos that you show, and the different angles that you show is going to make it really good and amenable for me to practice those. So I'll practice the Laurel and the continuous. I think I know in my head what to do, but but if I see it in a video, and then the pace that you go at was just perfect, but also awesome. There's the ability to pause and watch again and watch again, which for me, when I was previously looking at textbooks and even online, looking at diagrams, or the drawings and stuff, illustrations, I just can't learn like that. I should actually see someone to do it, and I think your point is great that you must implement, like you said, do the Laurel and do it straight away. I want you to do it tomorrow. When I've learned sutures in the past, I've learned, some way of, on the extraction course, and maybe just a little bit thrown in there, oh yeah, do the suture. If I don't do an extraction soon, I don't practice that specific type of knot or technique, you forget exactly, oh, is it this way, is it that way? And then in the, I'm already running late. And the pressure's on, and my nurse is looking at me like, hurry up. And at that point, you're like, okay, single interrupted, the one that will fall out in a week. So I think it's great to have that kind of resource to look back on. Amazing. So with those different techniques that you show, I'm looking forward to practice them on the models. Mm-hmm. One other suture that I use is the horizontal mattress and whatnot. So particularly after an extraction, like a purse string, draw everything together. And a variant of that, which I learned when I was in Singapore, is the cross stitch. So instead of going like as a square, you're just going diagonally one across. So it just makes like an X sign. And that's something that I use. It's a similar variant. Is that the main indication for a horizontal? And when would you actually use a vertical mattress suture?
Good question. So what you're talking about is what we call the figure of 8 suture, where you form an X across. And that suture is actually ideally used during socket grafting, because you can place something in the socket and it'll form an X or almost like a net on top of it. It's a great suture. One of the issues I think you may have with those sutures is when you tie your knot, it bounces up. Do you find it hard to get the knot flat against the tissue?
Yes, I know what you mean.
Okay, so that's a tricky thing. And in the course, there's something I call the modified surgeon's knot. It's where you do 3 forward throws, 2 reverse, 1 forward. And that'll help you get that tighter. Just a little tidbit. But that's a great suture to close an extraction site. But I want you to try the Laurel. The Laurel
Yes.
is going to change how you see extractions. Completely change it.
Amazing.
You're going to call me
Amazing.
tomorrow.
I'm doing so much more sectioning and elevating, so the need to suture here, and obviously
Yeah.
with my evolution, I want to be able to help I'm referring more to the implantologist, and
Exactly.
I'd like to help him with the grafting.
Yeah.
So I think that's where it's going to come in. And yes, excited to learn the royal technique. When would you use a vertical? I've never had to use, probably because of the lack of knowledge or experience. But what is the indication for vertical
What's
mattress?
the difference between a vertical and the horizontal mattress?
And when would you
it?
use the? Yeah, exactly.
So the difference between the two, and when you think about it, the horizontal mattress has two entry points, which are basic, say mesial and distal, right? When you close, and say you're trying to bring together the tissues with a little tension, if you pull too tight on the knot, you choke the tissue, because it's the knot is horizontal across. So the horizontal mattress can actually be used. I'm just going to give a clinical example. Say if you're biopsying something, you can actually place a horizontal mattress at the base of it and cut your lesion out, and it holds hemostasis.
Clever.
Right? Think about that. But is that necessarily what you want when you're grafting a site, to choke the blood supply? That's what you don't want.
I love the way of saying it, choking. It's a perfect term to use,
Right?
actually.
So the vertical mattress takes the horizontal mattress, and because now you're looking at a more apical and coronal entry point, it does the same thing but doesn't choke the blood supply. Mm-hmm. And say you're trying to be really delicate and bring a papilla up together, the last thing you want to do is choke the blood supply. You could use a vertical mattress to bring the papilla up.
Got it. Very good. I think as a GP doing more and more surgery, do you think a vertical is something that is a natural evolution sort of technique to learn beyond horizontal mattress? Do you think it's essential in surgery?
I think it'll have its advantages. Say bringing tissue up and not choking the blood supply very delicately, like say bringing a papilla up, it does. However, for closing it, then you may want to look into, there's suture techniques named after different surgeons for different scenarios. So we go over a lot of them: the Laurel, the Biddlestone, the Ford. A lot of these ones meant for these scenarios of grafting and others.
Very good. And when we come to tying the knot, I mean, you mentioned already making sure that we don't choke it, tension-free. Yeah. Is there a description or a guideline in terms of, tomorrow morning when we may be suturing, how tight do you want to go? Is there a guideline? Is there a test? If you've choked it, how do you know you choked it? How do you know you're too loose? Like a lot of mine are guilty of being perhaps too loose, and I justify it in my head like, yeah, you know what? I'm not choking the tissues. I'm not choking. But is there a guideline as to how tight they should be?
Blanched after you've tied down. What you want to see, and when you throw your knots down, there's various types of surgery knots, and so there's the most common surgical knot is 2 forward throws, 1 reverse throw, right? So 2 times clockwise or counterclockwise, then you reverse it. And then there's what we do, the modified surgeon's knot, which is 3 throws, and it has its advantages and disadvantages. But what you want to see is when you do your first throw, you want to see those threads lay down nice and flat against the tissue, not with a lot of tension, because you don't need a lot of tension. But you want to see that first throw lay down flat. And then when the second throw comes down, you want to see it lay neatly on top of the first throw. Just locks it in. And then you add on a couple extra just to secure the knot. But it doesn't have to close with a lot of tension. The knot doesn't, it just has to lay down flat against the tissues.
So it's lay it flat, but no blanching. And previously, now that we're talking numbers and throws and stuff, from the background I come from, the way I was taught was 2 in one direction, 1 in the other direction, and then 1 again in the opposite direction. Is that acceptable? Because I know there's so many variations. Is that okay?
Yeah, that's fine. Sometimes.
But is that the Nabeel Cajee way? Is that the Nabeel Cajee way? What's the Nabeel Cajee way?
Yeah, you saw I was like, yeah, you can do that. When part of my training was seeing special needs individuals with special needs in the operating room, and one of our rules was that knot better not come loose. Because if those stitches came loose, that patient has to go back to the operating room because you can't see them otherwise. So, and these aren't patients that are compliant. They're going to intervene. They're going to want to play with their sutures.
So this is under general anesthetic or sedation?
Yeah, under general anesthesia.
Got it.
So And if those sutures weren't tight, we had to cut them and tie them again if they weren't secure. So we would do 2 forward, 1 reverse, 2 forward, 1 reverse, 2 forward, 1 reverse. Six throws.
That many times? Okay.
Stacking it that many times. I think that's, in a general practice, you don't have to do it that many times. But at this stage, I generally go 2-1-2-1.
2-1-2-1. Okay.
And the reason for it is, if you see, when you look at your knot, the 2 forward throws, it's like 2-1-2-1. The knot just locks on itself. And there's something called the square knot, which is generally 1 forward throw, 1 reverse throw. But when you look at it, 2 single throws can actually unravel on itself a bit, but technically we're stacking the actual surgeon's knot. And that's just so much more secure.
Amazing. Well, you've answered my main questions I wanted about suturing, and I think there's a lot of nuggets there for everyone to go away with, and when they place in the next suture to realize about, putting too much tension, the different ones available. But I think it's maybe inspired people, for those who are thinking, okay, I need to improve my suturing skills. What's the next step? I think your course is the answer for that. Tell us about the making of this course. What is the mission statement, and how you think that this is changing the sort of way that we can learn sutures?
Who I had in mind when we made this course is essentially the surgically minded GP. Someone who's been wanting to get into implants or been placing them for some time and now sees some of the challenges. Someone who sees, wants to jump into some soft tissue grafting, someone who wants to do some wisdom teeth. But there's essentially a rule that I live by, which is only open what you can close. And so you're seeing these scenarios and you want to close them right. And essentially it's 3 things. You want to close these right because excelling at suturing does 3 things. It helps patients heal better, less complications, eliminate dry socket from your practice with good suturing, essentially. It allows you to grow as a clinician and take on more surgery cases, because if you find that fun, well, why not have fun every day? And the other part to it is, I really believe suturing is the signature you leave on your surgery cases.
Wow, I love that.
I really believe that. I love it. And I take great pride in this, where when I'm done with a wisdom tooth case, I hand my patient a mouth mirror and I say, look inside. I want them to see the suturing work. And when they're like, wow, I'm not even bleeding. It's clean. It helps everything. Suturing is not one of those skills you leave dental school and you have all of them. And my goal is just to give that dentist who really wants to get into these cases and do that type of work, as much as I can give them from my experiences, my training, and understanding, to be able to read scenarios on a clinical side and then apply, if we want to move tissue in up, down, as well as a good understanding of the fundamentals, which would be, what types of threads are out there, what are their pros and cons. Though these are lectures of their own.
But that's why the videos are just so clear in demonstrating, in terms of clarity of the lessons, the pace, and the ability to rewatch again and again and again. Because my evolution, and it just came at a perfect time for me as I'm venturing more into perioprosto. I'm actually going on, in 15th July, I'm going on, this dentist called Billy Arshad in the UK. He's a fantastic clinician, and he's doing a perioprosto course.
Very cool.
And I can see myself getting more into more crown lengthening cases in the future. So I want to arm myself. So back on that question I was going to ask you. Crown lengthening, functional crown lengthening on the palatal side of the upper canine to canine, and you've removed some bone. And then now you're, and obviously cut some gum away, and now you're approximating the tissues back. Obviously, cases vary, but what is the kind of suture that you would use for that kind of case, if you were to visualize that case now?
So you straight across canine to canine.
Yes, correct? I scalloped. I removed about 2 millimeters of gingiva, a scallop palatal side. I did not raise any flap labially, just palatally. And then to approximate the tissue. So what I just did, because that's all I knew, I did between each papilla, I did a single interrupted.
Yeah. Yeah.
Okay. Is that okay? And then is there something else that could be a bit better? And I probably use 4.0 Vicryl. So again, the result healed fine. I'm now in, it's part of my full mouth rehab. It's now onto crowns, and I managed to gain the ferrule that I wanted. But that signature that I leave on my patients at the moment, I feel as though it's going to be better now that I found you, but it's something that I'm working on. So is there any way that you would approach this kind of scenario?
Generally, whenever I'm laying flap, tissue back against the teeth, and you want to, especially moving the papilla exactly where you want them to go, and that type of approximation, I look to a sling suture or the continuous sling. It's just, you have so much control over how the papilla get laid down. It's amazing.
And you cover that on the course, right?
It's definitely in the course. It's a great suture. It is a little tricky. I mean, I love that you jump straight into, you're like, I'm not even going labial, I'm going palatal. I admire your,
I had good mentorship, Nabeel. There's a periodontist called Amit Patel who really sat with me and said, okay, this is the game plan. He drew the diagrams for me, and I had a little bit of experience, and I was doing more surgery in the last 3 years, more than I ever have before. So, and the case went brilliantly. I was really proud and really helped my patients. So it was at the right time for me, but I know I'll be doing more of this in the next 3 to 5 years. It was your course came at the right time for me in terms of my learning needs.
Yeah. I mean, for a lot of those, for me, it's as I said, the continuous sling. I would probably have gone for a 5.0 polypropylene suture or a 5.0 PTFE suture. I think for these cases, the Vicryl is a great suture, but when you see how, when you jump to the 5.0 suture, the needle also changes. You probably have, what was used, an FS2 needle, which is a little bigger, and the ability just to slide through these tissues and control them. And you'll just see how gentle these sutures are then to the actual tissue. You fell in love when you got married, and when you had your child, you're going to fall in love again.
Absolutely. Yeah. I love that, buddy. Thank you so much for giving up your time. And there's a little discount code that Implant Ninja team have given us. I'll share that in the outro with everyone so that they can check out your course. I'm excited to learn the Laurel. I'm excited to now go back and see what I should have done with that crown lengthening case. But one thing I was going to say in the intro as well is there are two types of courses, Nabeel, right? There are these courses which do have some degree of return on investment. Like if you go on a certain type of, if you got an implant course, learn how to place implants, then you hope that in 5 years' time, you're going to make a return on investment on that implant course. With suturing, I agree with that. It may reduce a dry socket. It may reduce post-operative complications, but it's difficult to assign a bottom line to better suturing. But there's nothing better than having the confidence that, my suture is going to stay. This is my signature, just like you said. I love that. And having the knowledge and the feeling that you're giving the best surgical care to your patient, you can't put a price on that, right? There's no ROI needed. That is the ROI right there. So that's the category that your course comes in how I feel. So I'm excited to really practice. And what I'll do is a crown lengthening case I do. I will DM you on Instagram, share your Instagram in a moment, my suturing of the sling, and I cannot wait to do that, my friend. Tell us your Instagram handle, my friend.
It's at Dr. Cajee.
At Dr. Cajee. Amazing. Everyone, check out Nabeel and his work and his journey as a new parent, relatively new parent, and all the implant stuff that he does. Any final words while you have the microphone to the world of dentists, mostly UK, Europe, but now US, Canada, Australia, New Zealand? What do you want to say to everyone on this topic?
Well, first of all, Jazz, I just want to thank you for having me tonight or this morning on your side. And, to the world of dentists, I think dentistry is just such a beautiful field that we have the opportunity to grow on a daily basis, to grow on a career path. Where your skills are today and where you'll be in a year, 2 years, may be completely different. And I really want to see our generation of dentists really defining something new for the field, bringing new technology, new techniques to the forefront. I I really want to see us practicing like we're in 2022, later on, like we're in the future. And I just really hope that, what you experienced with us during this podcast was valuable. And if you choose to take the course, that it really benefits you.
It certainly will, my friend. Thank you so much for giving up your time. Well, there we have it, guys. Some great inspiration there for suturing. If you're on that journey like I am, sometimes little things that we take for granted, like suturing, is exactly the kind of thing that you need to do to feel more confident about your overall surgical skills. So if you want to level up your suturing, head to protrusive.co.uk/suture, and it will take you straight to where you want to be to enroll in the class. And as part of the Protrusive discount, that famous Protrusive discount code, if you use it on there, you will get $70 off. Now, if you're international people, i.e. if you're outside the US, you will get $70 off, and that will be reflected on the shipping, because the shipping is quite dear. It's about $100 or so. So if we can knock off $70 from the shipping, that makes it a bit more palatable. Now, it makes sense why the shipping is so much, because it's medical equipment being sent to you and the models and stuff, which you get to keep, obviously. So that will take care of the most of the shipping for you. But if you're in the US, then you can knock off $70 off the overall price of the course. So check out protrusive.co.uk/suture, and we'll take you straight to the Implant Ninja School, where you can enroll to level up your game in suturing. Thank you so much for joining me, and I'll catch you in the next one.